Welcome, everyone. You know, um, I don't do a lot of webinars, but it's interesting that I've done two in the last month, but I've done two that are very important to me. And this one is this therapy we're going to talk about, I think is really cutting edge, and we're very excited that our group has become one of the national leaders in this therapy over the past 12 months. So we're going to talk a little bit about it. Enough about me. So I'm going to pull that up so I don't have to see any of this stuff because it gets in the way of my slides. So why are you here? Well, I hope you're here to learn a little bit about prostate cancer, about some of the newer treatments, a little bit about diagnosis. I think that probably everyone listening knows someone who has prostate cancer, has had prostate cancer, if not one of the actual um, members listening tonight. And we have come a tremendous way in the treatment of prostate cancer since I first started my training in urology in the 1980s. Um, really, it was not very good radiation, and it was often surgery with poor results. So all of the treatments have dramatically improved, and some of the new ones we're going to talk about. Prostate cancer is 99% treatable if caught early, and survivals are excellent for localized disease. Once the cancer is outside the prostate, it cannot be cured, which is one of the interesting challenges, that it's highly curable if it's in the prostate. It really cannot be cured once it's outside. We all know about a little bit prostate. It's mainly a fertility organ. It has little use after childbearing years, except to provide a reasonable level of income for your local urologist. Um, it's a small gland, about the size of a walnut. Some are much bigger. What it does, it provides components that help nourish the semen and the sperm cells, and helping them get there and helping them stay nourished through fertility. Why does it start growing? We don't really know, but around 50 years old, it starts growing. Prostate cancer is also a disease as you get older. That's why we start screening patients in their late 40s and early 50s, not screening them when they're 20. Um, what is prostate cancer? What is all cancer, really? What all cancer is when a normal cell becomes altered by its DNA and its genomic material and starts having uncontrolled growth. By definition, cancer is uncontrolled growth. That is not the same as benign prostate growth, which is actually just growth where something is normal cells, they just grow more of them. So there's a definite difference between prostate cancer and BPH. What are the causes of prostate cancer? For the most part, we don't really know. We know it's a genetic disease, obviously. We're learning more and more about genes of prostate cancer. There are literally dozens of prostate cancer genes. It does share a link with BRCA, which is a breast cancer gene. And so we find that there's a relationship there. Environmental links probably are an important part. The good old American diet of what I call the high fat, low protein diet tends to increase the risk. We know this from Asian men who in Japan have very low rates of prostate cancer. Within 5 to 10 years of the good old American diet, their prostate cancer rates start approaching Caucasian men in this country. So there's clearly some environmental and lifestyle changes. It's not really obesity itself. It's just the fact that the diet that makes you obese probably increases your risk of prostate cancer. We talked about first degree relatives. Obviously, if your father and your brother have prostate cancer, your risk gets higher. We talked recently, I just mentioned the BRCA gene. African American men seem to have some of the highest rates of prostate cancer in the world, and their cancers tend to be more aggressive. So in a metro area like Atlanta, with a large population of African Americans, we have a significant outreach to reach these gentlemen, to screen them for cancer, because their risk is significantly higher. But hopefully, if we find them early, once again, you find a localized prostate cancer, it's curable. The whole goal is finding prostate cancers when they're localized. We're not going to go too much into symptoms, because most of the time, I would say 90% of my patients who have prostate cancer have no symptoms from the cancer. If they have symptoms, it's usually from the benign growth they have. So I always tell a patient, if you have symptoms and it's because of your prostate cancer, that cancer is probably spread either locally outside the prostate or a distant spread. So I try to make this very clear with patients. Why do we screen patients so aggressive for prostate cancer? Because really, there aren't going to be symptoms in the curable state. So it's great that we see patients with urinary symptoms, but most of the time those patients have urinary symptoms because of the benign growth. Because the benign growth grows in the channel, most prostate cancers occur on the outside of the prostate, or what we call the peripheral zone. A very important point. How do we screen for prostate cancer? It's changed a lot. The digital exam we'll get to in a second, but the mainstay of screening for what we call our primary care doctors uh, has been PSA testing for at least the last 25 years. PSA is a protein made by the prostate gland. Nothing harmful about PSA, but we know that when the levels rise significantly, it may be an early warning sign of prostate cancer. I still believe in the rectal exam with PSAs above 1 because many of the prostate cancers I find are found with PSAs in the 2 to 4 range. So we actually start screening a lot of our patients with PSAs that are actually normal because once a PSA gets above 2, the lifetime risk is not insignificant. I won't get into a lot of the other, but there's a lot of other screening tests that we're using now in our office, which look at genomic particles or different types of PSAs. For the purpose of this discussion, PSA is still the mainstay of screening. What's the incidence of prostate cancer? It's the number 3 type of prostate cancer. The second most common organ cancer. Skin cancer is the most common cancer. But it's actually more important than being one of the most common types of cancer in the U.S. It's actually the number 2 cause of cancer death after lung cancer. So it is still a significant cause of cancer death in our country. And that's why it's so important for us to find these cancers when it's localized. Very common cancer, about 1 in 8 men during their lifetime will be diagnosed with cancer. I will briefly have an aside that we don't treat every prostate cancer now. We've learned a lot of lessons that prostate cancer is a continuum. That is low grade, slow growing prostate cancers. We can watch a lot of those. And I have hundreds of patients now that I'm watching their cancers. This will lull a lot of people into thinking that prostate cancer is a benign disease. However, it's a continuum. And as the cancer cells become more aggressive, we diagnose cancers over here, which are very aggressive cancers. These patients need treatment because these are the patients that if we don't treat, they may be one of these 33,000 men who die of their prostate cancer. 1 in 6 Black men will be diagnosed in the U.S. with prostate cancer. And once again, it's a very important screening for us in the Metro Atlanta area. It's usually a disease of older patients. I would say 50 to 60% of our patients we diagnose are over 65. I think we're finding them a little bit younger now because I think some of our screening techniques are getting a lot better. So I think we are finding these cancers earlier. And as I've said several times now during this conversation, the earlier I find the cancer, the more likely I can cure that patient's cancer. So how do we diagnose it? The mainstays of diagnosis at the end of the day is going to be a prostate biopsy. But we are using a lot of prostate MRIs right now. Bone scan, CT scan have really gone by the wayside. I'll remind myself to remove those from my slide. I generally get a prostate MRI on pretty much every patient that I am going to do a biopsy on. And the reason is because if I see a target on the MRI, I'm going to do a different type of biopsy called a fusion biopsy, where I would take the ultrasound images done real time, create a 3-dimensional model, feed the MRI into the computer, create what's called a fused image. And that way I can target by moving the ultrasound, it will target that little area, maybe that big in size. So I do a lot of MRIs. PET scan is reserved to make sure the cancer is not spread. It is important for recurrent disease, and we'll get to that in a moment, because NanoKnife or electroporation has not only a goal of focal treatment of prostate cancer in the localized state before any other treatment's done, but also highly utilized for what I call recurrent prostate cancer after radiation. Treatment options. As I said before, many of our patients, we have them on active surveillance. We don't just diagnose them and say, hey, your cancer is slow growing, we'll see you in 20 years. We're going to be checking you very closely because about a third of those patients on active surveillance will eventually require treatment. So we're going to watch these patients very carefully. What are the standards of care? Well, the standard of care for treatment is what I call whole gland therapy. We are treating the entire prostate, either surgery to remove it or some type of radiation therapy, either brachytherapy or some sort of external beam therapy. The newer treatments where we focal and we localize just treating the cancer itself, there are several options. IRE or NanoKnife, we're going to talk a little bit about that tonight. High intensity focused ultrasound using ultrasound waves has been around for a number of years. It has have some utility. We are offering that as well. It doesn't treat the cancers that are higher up in the prostate, more near the top of the prostate, because those cancers, the ultrasound wave has to travel too far to treat them. So we try and tailor that toward patients. Cryoablation's been around for a while to treat radiation failures, a little bit higher side effect profile. So we're sort of getting away from that as the NanoKnife comes into play. We do not offer focal laser ablation, but I offer patients, if they're curious, they can read about that as well. Standard of care, we talked about robotic prostatectomy. You know, I've done hundreds and hundreds of surgeries the old-fashioned way through the incisions in the lower abdomen, but we have young guys in our group right now and some older guys who are excellent at robotic surgery, small keyholes, remove the entire prostate. For some cancers, it's absolutely the standard of care. We're not here to simply say tonight that focal therapy is the only way to treat prostate cancer. It is definitely not. But I think robotic prostatectomy is the standard of care for curing prostate cancer. You remove the whole prostate gland, hook everything back together, overnight stay in the hospital for 95% of patients, and our guys are very talented at doing it. Radiation therapy, you know, it's basically highly sensitive to prostate cancer. They've improved it tremendously with computer programming to make sure that the radiation beam is really focused well. It's an outpatient treatment, does not involve surgery, so no incisions. You can do and combine it with seed implants, which is another common treatment. It's radiation is usually a Monday through Friday, 5 minutes of treatment for about 6 to 8 weeks. So it's a prolonged treatment. But once again, it treats the entire prostate. You don't just radiate just a small area. It's really not set up for that. What does focal therapy mean? It is basically, and all these you can read them here. It's NanoKnife is a minimally invasive treatment, uses non-thermal energy. We're going to explain a little bit what non-thermal energy means. And it creates tiny pores in the cells themselves. So then the components of the cells leak out and the cell dies. High frequency ultrasound ablation uses ultrasound to destroy the tumors. Cryoablation, we know what cryo means. It freezes the prostate, and laser heat can destroy tumor cells as well. So this is sort of our basic slide panel about how do we do localized treatment. Well, if we're not going to treat them, we're going to put them on active surveillance. If we're going to treat them, for us, it's either surgery, some type of radiation. I would include proton beam in that. Proton beam uses protons, whereas radiation uses photons, but it's generally an energy beam, or some sort of focal therapy, of which we're going to talk a little bit more about, NanoKnife. And it's not just the patient picks out which one he wants. I want to be very clear about that. Our goal is to tell and guide the patient to the treatment options. And for some patients, all of these are options. But for some patients, there are certain reasons why radiation wouldn't be an option for a patient. If his prostate's 8 times normal size, I would not recommend radiation for that patient. The patient's 80 years old with bad COPD and heart disease, I'm probably not recommending surgery for that patient as well. So our goal is to discuss what options are there and why some are not. So let's talk about NanoKnife a little bit. I first heard about NanoKnife probably about 2 years ago, and saw some articles on it, was quite intrigued. So this past year, we started offering it in several of our offices, probably 4 or 5 of our doctors are doing it right now. I think there's 4 of us, myself included. And I went up to Cornell up in New York, and I saw the sort of the guy that's been doing it for a number of years, and saw how he did it, and said, we can certainly offer that here, and came back and we started our program. Um, you know, this is a slide that's a little busy, but it tells a little bit about what's grade group 1. Well, we talk about Gleason score, and if some of you have prostate cancer, you probably heard about the Gleason score. The group 1 is patients who have a Gleason 3 cancer. Those are what I call low grade. Those patients can often be under surveillance. Grade group 2 and 3 is patients with 3+4, that is, have a little component of that Gleason 4 component, which is a more moderate or a little bit more aggressive cell type. Whole gland therapies for those patients for a number of reasons, but they may have Gleason 4+4 or 4+5, but it's localized. Those patients are going to need whole gland therapy. So what does the idea of organ sparing mean? It means that how do we limit the side effects of treatment, which is really our goal. The holy grail of all of this stuff is how do we cure the cancer and limit the damage to vital organs. And what we mean by that in the prostate is erectile dysfunction, urinary incontinence, injury to the rectum, the risk of surgery, bleeding, infection, scar tissue, all these things. So, the less damage we can do to tissue, the better. What I like about NanoKnife, it doesn't preclude other therapies down the road. In our experience, we have seen no erectile dysfunction and no urinary incontinence in probably the first 50 or 60 we've done. And mainly we're trying to treat just where the cancer is. So let's get to what electroporation is, because that's a term I never even heard of until 2 years ago. I guess the chemists all know because it's a very commonly used thing in chemistry, but I didn't know about electroporation until a couple of years ago. But really what it does is it uses electrical energy, but non-thermal. What do I mean by that is thermal energy is how you burn stuff. That's how you burn tissue. And, we burn things to treat things. We burn things all the time using, thermal energy to remove prostate tissue, and some laser energy is certainly thermal. It burns tissue. So, but non-thermal electrical energy, what it does is create small holes in the cell's protective layer. We call them, little nanometer holes, or even smaller. And that's where the NanoKnife term comes from, because it sounds sexier than electroporation. But what it does is create small holes in the cell's protective layer, and the internal contents of the cells leak out and the cells die. So it destroys the targeted cells, but preserves all the tissue around it, including nerves, blood vessels, stromal, smooth muscle. So it's a very precise sort of treatment. This is a photomicrograph of some of what electroporation does. And the time is, we start the pulsing of the energy, we start seeing it obviously 3 milliseconds, we don't see anything. And at 3 milliseconds, we see a couple of holes here. And at 40 milliseconds, a few more, and so forth and so on. We're creating all these little holes in the cell. And so we give this pulsed electric field literally over 10 minutes. And I'll talk a little bit how we do it. And hopefully we're going to create this zone of treatment. So how does IRE promote cell cancer death? Well, the intact cells are targeted. We do the irreversible electroporation. The cell membrane gets disrupted. All the stuff leaks out. The cells die, and then basically the phagocytes of the body just eat the dead cells up and clear them out over a number of days. Before I get to that slide, I'm back up here. So how do we do it? Because I don't really have any slides that tell you how we do it. But basically, we put the patients under anesthesia. We usually have an MRI, hopefully, that can show us our target. And we put an ultrasound probe, just like if we do a biopsy, we put an ultrasound probe in the rectum. We map out the prostate in 3 dimensions, create a 3-dimensional map, feed the MRI in, so now we know our target. And so we create, using a grid placed over the area between the scrotum and the anus called the perineum, we're going to place a little grid over that area, just like a battleship. A, B, C, D, E, F, G, 1, 2, 3, 4, 5, 6. And we're going to place our little needles through that skin, and using the ultrasound, we're going to see right where those needles go. And we're going to basically surround our area of concern with this field, this electrical field that's going to send this energy via these needles, almost like a force field, to treat the cancer. Once we get our needles placed, the treatment is 10 minutes. What does whole gland therapy risks and have? I mean, surgery and radiation, it can have risk of incontinence, significant risk of erectile dysfunction, significant risk of rectal and GI issues, can cause chronic overactive bladder. Patients have radiation changes in the bladder causing radiation cystitis. I think radiation can lead to a long-term risk of bladder cancer. I've treated dozens of patients who've had radiation who had no significant risk factors to get bladder cancer, such as smoking, and develop bladder cancer. So the goal of focal therapy, the whole philosophy behind it is how do we treat the cancer adequately and yet maintain the quality of life for our patients as it relates to erectile function, urinary function, and bowel function. That's where the whole goal. You are never going to hear me tell a patient that focal therapy is going to be a better cure than whole gland therapy. I don't think that's what we're trying to achieve here. I think we're trying to balance a treatment that we think is going to be highly effective and hopefully curing that cancer, but also maintain quality of life in the other areas that are important. So lesion ablation, 94% success we've seen with ablating the lesion. What we do is we're going to get an MRI at 6 to 12 months and see if we've got this lesion ablated. We're also going to follow PSA. And looking at some of the studies that are out there, at 3 years, there seems to be no difference between IRE and radiation. So I like that early data. I'm waiting to see 5 and 10-year data, but so far I'm very excited about that, that success rate. We can retreat. There's really nothing to say that you can't retreat an area with NanoKnife. You can't do radiation again. There's no doubt about it. I'm going to mention briefly about the application in salvage therapy. We have done a number of patients who have had recurrences after radiation. You really can't remove a prostate after radiation therapy. It's really hard. The risks are extremely high. So traditionally, we did cryotherapy for those patients. We're now switching these patients over to NanoKnife because we think it's going to be just as successful with, I think, much less side effects. So radiation failures, these are excellent candidates for NanoKnife. I moved pretty quick there because I want to leave some time for questions and I don't want to interrupt everyone's dinner hour. But what are the key takeaways? All right, guys, get screened. I mean, if you're not getting screened, over the age of 50, that's the start. Get screened. I think if you have a PSA above 2 consistently, you ought to make sure you get a digital exam because a lot of our primary care doctors are not doing digital exams anymore. I don't love it, but that's how it goes. So I think if your PSA is above 2, you ought to get in to see us and let's at least do an exam, maybe do some of these more advanced screening tests that we do, looking at genetic particles or different types of PSAs. Know your family history. Family history of breast cancer is going to increase your risk of prostate cancer, fellas. So keep it in mind. And know that there's options out there besides whole gland therapy. It's not just surgery and radiation anymore. We've got other treatments that we can talk about and discuss. I'm going to open it up for questions. I hope I didn't go too fast. I hope I didn't bore everybody. We're excited about this therapy. We're looking forward to doing it. I will mention that it recently got its Category 1 code for prostate cancer specifically. Traditionally, the electroporation codes were for all types of solid tumors, but it got a specific code just last month for prostate cancer. And we anticipate that there will be no insurance issues with this, 12 months from now. Right now, Medicare fully covers it. Straight Medicare fully covers it without any issues. But we anticipate complete coverage, 12 months from now. I'm going to bring CJ back on. If there are any questions, I'd like to hear about them and we can talk about it.
Fantastic. Thanks, Dr. Capelouto. So like I said before, go ahead and hit the chat button and feel free to ask your question, type in your question. It will only be seen by myself and Dr. Capelouto. So I'm going to prompt Dr. Capelouto, with these questions, which are fantastic. So thank you. Keep them coming. Um, you spoke, Dr. Capelouto, you spoke about the risk factors. One of our attendees would like to know more about minimizing the risk. Maybe give us a few tips that you would offer that could lower that risk.
I think minimizing risk is a challenging discussion. I really think, you know, low body weight, high fiber, low fat diet over the course of years is going to help prevent prostate cancer. There's some limited data on lycopene helping to reduce the risk of prostate cancer, but some of the mineral things like zinc, saw palmetto, the data is just not very clear that it helps prevent it. In patients who have very large prostate glands, there's some data that finasteride and dutasteride can help lower the risk of prostate cancer. But I would urge patients caution with reviewing the web because old data talks about those medications can increase the risk of high-grade cancer. That data has been mainly disproven. So I think those medicines can help lower the risk of prostate cancer in some patients, but I tend to reserve those for patients who have really big prostates because it'll also help both with their urination.
Fantastic. And why do Black men have a higher risk?
It's almost certainly a genetic factor. I don't think it's simply a dietary issue. Jamaican men have the highest rates of prostate cancer in the world, but African American men are second. So it's clearly has to be genetic.
And you mentioned the Gleason score. Maybe you could give us a little bit more on that. How do you determine the severity of the cancer?
When we do a biopsy and it has cancer, every cancer is going to give us a Gleason score. As I mentioned, there are basically three scores. There's a 3, a 4, and a 5 of increasing aggressiveness. So 3 is the least aggressive, 4 is up there, then 5. So a Gleason score is going to combine the most common cell type and the second most common cell type and give us a number. So for instance, if the Gleason score of the cancer is a 3 and it's all 3, the score is going to be 3 plus 3 equals 6. If it's mostly 3, but it's some 4, it's going to be 3 plus 4 equals 7. A little different is 4 plus 3 equals 7. So they're both 7s, but notice the 4 is a more common cell. So that most common cell type takes precedence. And it can go from 4 plus 3, 4 plus 4, 4, and so on. So it's combining the most common cell type, the second most common cell type, and getting a number. That number will be between 6 and 10. The higher the number, the more aggressive the cancer.
And to answer a misconception or maybe a confusion here, one of our viewers has seen lots of commercials about Urolift. Can you sort of tell us how that does not relate to prostate
Well,
cancer?
Urolift is a treatment for BPH. It's a treatment for benign prostatic hyperplasia. It is a treatment for opening up the channel. It is not going to have any relationship to treating prostate cancer as a treatment for benign growth and obstructive symptoms. Completely different.
And then can you give us a little more information on what active surveillance looks like?
Well, active surveillance simply means that we're gonna watch these cancers, and I will tell you there must be 20 or 30 different protocols out there in the United States for active surveillance. You can look them up and what the Mayo Clinic does and what Sloan Kettering does. But in general, for my active surveillance patients, I'm gonna probably get a PSA every 4 months. I'm gonna get an MRI every year, and based on their age, I'm gonna probably get a biopsy every 18 to 24 months. Why do I say based on their age? Because a patient will basically age out of me getting further biopsies. Say if they're 80, 82, 83, I may just follow PSAs only. And if the PSA changes, I might then move to an MRI or I might move toward a biopsy. But in general, PSAs every 4 months. Occasions the patient, if they're stable for years and years, I might go to every 6 months. But we're going to be checking those patients pretty closely with PSAs and generally an MRI every year. And as I said before, about a third of those patients will eventually need therapy because guess what? The cancer grows.
Fantastic. And I do want to mention that we can't, of course, give any medical advice for a particular situation because obviously we may not have seen you, but a quick question from a viewer, and should he be concerned? He's 74 in good health.
Mm-hmm.
His latest exam was his PSA was less than 1. As of last month, it's 1.21, and
Mhm.
his brother had prostate cancer in his late 70s. Is that a area
Yeah,
of
these are my thoughts. You know, I've diagnosed for if you look at my whole career, how many times have I diagnosed prostate cancer under one? Twice. Between one and two, a handful. And I probably, you know, if a patient hasn't had an exam in many years, I probably recommend an exam. But the risk of cancer between PSAs of one and two is extremely uncommon, but not zero. Once the PSA gets above two, the risk has become significant. And literally just today, I saw a patient with a normal PSA, but it was rising. And we did some further testing. And eventually, even though his PSA was normal, he ended up having a very, very significant cancer and will absolutely need therapy. So you know, PSA is not an absolute. It's a guide, but it's not an absolute. And that's why I think there's a gray zone to PSA. If you have concerns about it, you know, we're happy to, you know, see the patient and, you know, give them an exam. But in general, the PSA goes from zero point 0.9 to 1.2. What I normally would tell these patients is you actually need 3 data points because the PSA goes from zero point 0.9 to 1.2. It's very likely the next time you check it in 3 or 4 months, it's back down to 1 or zero point 0.9 again. So you need to have a bump and a bump and a bump for me to have concerns for PSAs that are in that lower range.
And what is the recovery time after NanoKnife?
So NanoKnife, generally what we do is we keep a catheter in for about 3 days just because there's going to be some swelling, and we know this because we don't want you to not be able to pee and be back in the ER. So generally because there's no incisions, it's just some needle hold. I think that once the catheter's out and the patient, you know, is voiding, there might be a little bit of frequency and urgency for the patient for a few weeks, but pretty much we let them start doing the next week what they're comfortable doing.
Fantastic. And how many IRE procedures have you performed, and how many has the practice performed?
We've done about 60. I've done about 8 or 9. I have 2 of them next week. So you know, we're getting our experience up to date. I am always 100% comfortable in telling patients how many we did. I had to tell one patient he was the very first. I mean, that's just part of practice. Even at 61 years old, there's sometimes now you're going to be the first, and patients have to accept that. They have to understand what we're trying to do. Having said that, you know, the procedure is the exact same grid as doing prostate seed implantation. It uses ultrasound guidance. It's the same grid, but instead of putting 20 needles in the prostate, it's really 4 to 5. And I've done 500 prostate seed implantation. So the treatment's very, very transferable. So, you know, we've done in our group thousands of prostate seed implants. And like I said, the therapy is very transferable in terms of the actual doing it, but it's early in our experience. You know, we're going to see how these results pan out, you know, and we're going to be, all the PSAs are coming down, which is great. We're, you know, when we get the year point, we're going to be checking these MRI scans. But, you know, we're literally a little bit less than a year of being involved in this. So we're very excited, but it's a new procedure.
And what might be your thoughts on active surveillance versus focal versus radiation versus surgery for a Gleason 7 3+4 on one lesion and two Gleason 6s 3+3s on other lesions with a genomic 10? And it's a 63-year-old male, family history, father with prostate cancer at 62.
Should I bill for this consultation? No, I'm joking. You know, I think that what people have shown in some of the research is that the dominant cancer is the one that spreads. And there are some studies that talk about this, that if there's a Gleason 7 on one side and some Gleason 6s, the Gleason 7 is the one that moves along. So there is some evidence that you can focal therapy the 7 and leave the 6s alone and put those guys in active surveillance. You know, a 63-year-old guy with a Gleason 7 cancer, I'm probably going to recommend treatment. You know, obviously, if he's got a low genomic score, a Decipher score, it's really low, we can watch it. It also depends what's the percentage, and I don't want to get too deep down the rabbit hole here, but if it's got 40% Gleason 4, that's still a 3+4. If it's 5% Gleason 4, that's still a 3+4. And I think those cancers are different. That's
Um,
individualized is the key. Every patient's goals are different, and every patient's a little different. Their health, their status, their genomics. There's just too many factors to sort of try and pigeonhole into one therapy.
What is the time frame for a biopsy after an MRI that detects prostate cancer?
Well, if you have an MRI that's abnormal, and say, why do I get an MRI? Because there's some concerns. Either the PSA is elevated, one of the other screening tests are elevated. I feel something abnormal on the exam, and so I get an MRI. If the MRI shows a focal lesion, that is a lesion I can target, it's usually going to be, within 6 to 8 weeks. We want to get that biopsy done. I want to let everyone know that in general, prostate cancer works in months and years, not days and weeks. It is not pancreatic cancer. It's rarely an emergency biopsy for prostate, right? But generally, if we have an abnormal MRI, we want to get the biopsy in 6 to 8 weeks.
And does the choice of treatment depend on age? So someone's asking about a under 50 years old, if that changes the treatment protocol.
No, I don't really think so. I think that I have patients in there. I mean, you don't see a lot of patients under 40 with prostate cancer. We do see them, but we see a lot of patients in their 50s. But look, I'm going to offer a patient focal therapy in his 50s as long as I know that he's gonna be part of the protocol. He's going to get his PSAs, he's going to get his MRIs, he's going to repeat his biopsies, and we're going to follow him pretty tight. So, I don't think the treatments between 50 and 80 are really that much different. I think if you've got a more aggressive cancer at 50, I'm probably going to recommend removing your prostate. If you've got a little more aggressive at 80, I'm probably going to look more at radiation. Those include, continue the ones that aren't going to be candidates for focal therapy. So as I said before, it's highly individualized, but you know it's a lot of factors that go into what we decide how to treat a patient and their goals mainly.
And then another question about how you mentioned the cell sort of leaking its contents. When it is destroyed and the contents leak out, can that create cancer in other parts of the body?
No,
Um,
that's not how prostate cancer works. We get this question a lot when we do a biopsy. If we put a needle into the prostate, do we spread the cancer into the body? Zero. We even have patients who have active known bad cancers that is growing into the prostate channel. We have to resect that prostate cancer there just so they can pee, no increases of that cancer spreading elsewhere to the body. That's not really how prostate cancer works.
and then we have a patient who has been diagnosed and has an appointment with us next month.
Mhm.
And typically, how long after the consult can the procedure be done?
Usually usually it's 4 to 6 weeks as my time frame of seeing a patient before I can get them on the schedule for surgery. That's usually standard, but without knowing anything about the patient, I'm not sure that's what he needs.
Um,
That's my surgery schedule is about 4 to 6 weeks. This
and
time of
then
year, a little bit dicier because it's end of year and it is, and everyone's got their deductibles met. They're banging on the door.
and then we have a patient with who had a fusion biopsy with Dr. Mellis and is being recommended for focal therapy.
Mhm.
But Dr. Mellis mentioned he doesn't do that. So,
Nope.
how many docs at Georgia Urology
So,
do?
so there are 4 doctors in our group currently that are doing focal therapy. Myself, Dr. Dan Ballou, who's in our Cumming and Roswell office, Dr. Song in our Gwinnett office, and Dr. Sharp in our Brazelton office.
Got it. And then, can you comment on the Prostate Health Index score and Cipher score?
I don't use prostate health index much anymore. I don't find that more as useful as XODX or the ISO PSA or Select. So I don't really use the prostate health index score. Decipher score is a score that looks at genetic particles of the cancer itself. That's different. That's not a screening test. Decipher score looks at genetics of the actual cancer. I use it extensively because it helps me guide patients into whether I feel comfortable with active surveillance or do I think need to treat it. We've had some patients with lower grade cancers, but yet their Decipher score shows a very more aggressive genetic profile, and I tend to push those patients into therapy. If they're on the borderline and I get a really nice low Decipher score, which shows a lower risk, I might be more inclined to do surveillance on those patients.
And does the size of the prostate uh, inhibit or preclude this procedure?
We have found it not to be. I mean, I think that early on, some of the recommendations were, don't do the huge prostates. But I know that Dr. Sharp has done some really big glands and has done quite well. So I don't really have an issue of treating with focal therapy a bigger prostate, as long
Um,
as I have a focused lesion. Now, let me say this: if he's got a 10x normal prostate, I'm not going to really be aggressively doing an entire hemiablation that is treating the entire half of a prostate. I'd rather that be a smaller lesion I can focus on.
and if you do NanoKnife for a Gleason 7, would you also target the Gleason 6s?
I would not, unless they're in the same area. I can do, if they're on the same side, I can do a hemigland. But if they're separated by significant length, no, I'm probably just going to watch that Gleason 6.
And what does a PSA of 5 mean?
It means that you need to be evaluated.
And then a question about removal of the prostate. Is that the best option for a successful outcome and to be completely cancer-free?
In my opinion, nothing has been shown to be more successful in curing prostate cancer than removing the entire prostate. Is that required of every patient to have a long term to number one be cured or to have a long term disease free interval? No. Um, and like I said, it depends on every patient. But if we're looking at just sheer numbers, surgery has the highest cure rate.
Got it. Do testosterone treatments affect the risk of prostate cancer?
It will not cause prostate cancer. That has been proven. But if you have prostate cancer, it could make the cancer grow. So we are pretty cautious in patients who are on active surveillance who we're going to let stay on testosterone. It's one of those hard calls.
Got it. So for a patient who lives about 150 miles from Atlanta,
Hmm.
what kind of follow-up do they need to do, and how does the distance affect their treatment?
I would probably tell those patients, if depending on where they're coming from. And Georgia Urology has offices as far down as Fayetteville and as high up as Ellijay and as far up as Brazelton and as far over as Conyers and as far over as Douglasville. So our spread's pretty wide. So I need to know where he lives precisely. But we get patients from North Carolina and Tennessee and South Carolina coming to see us quite often, Alabama. So it's not a challenge.
And then does cycling increase the risk of prostate cancer?
No, might make your PSA go up. So if you're a big cyclist, I'd probably stay off the bike for a week before you get a PSA. Don't have any ejaculation 2 or 3 days before PSA because that can raise it temporarily as well.
And then if you get the NanoKnife and the cancer comes back, can you still get your prostate removed?
Yes. Look, I hope everybody learned a little bit tonight. I appreciate all the questions. I hope I answered everybody adequately. We are happy to, click on the link, visit us. You can probably maybe, set up a time to ask some more questions and we can kind of work through them. But it's a really exciting thing for us, and we look forward to sort of sharing our data and our results as we become more and more proficient.